Imagine this. A family waits anxiously. Their loved one is on a list, desperately needing a new liver.
Yeah.
For thousands, a healthy organ isn't just a medical procedure, it's a profound second chance at life.
It really is.
But the challenge is immense, finding suitable organs. Especially for livers, the demand just far outstrips the available supply.
It's a stark reality, absolutely. And this urgency has pushed the field to innovate, increasingly relying on organs from donation after circulatory death, or DCD donors.
Okay, DCD.
These are patients whose hearts have stopped. And while DCD livers are a vital and growing source, they face a unique vulnerability: damage from what we call warm ischemia.
Warm ischemia. Can you break that down for us?
Sure. Think of it as the period when blood flow, and therefore oxygen, stops reaching the organs right after cardiac arrest.
Okay.
Even a short period of this warm ischemia can cause significant cellular stress and damage. Then, when blood flow is eventually restored, either in the body or later in the recipient, it can trigger something called ischemia reperfusion injury.
Ah, the reperfusion part.
Exactly. It's a sort of paradoxical damage where the return of blood flow, which is essential, right? It can actually cause further injury because of a rush of oxygen and inflammatory compounds. And this initial warm ischemia and the subsequent reperfusion injury, it's particularly problematic for the very delicate bile ducts within the liver. It often leads to severe complications down the line.
So DCD livers, they offer incredible hope by expanding the donor pool, but they come with this built-in challenge, that initial warm ischemia.
That's the core problem, yeah.
And this is where some really cutting-edge medical breakthroughs have come into play, right?
Yeah.
Revolutionizing how we handle these delicate organs. We're talking about two major normothermic perfusion strategies, methods that keep the organ at body temperature.
Correct.
First up, Normothermic Regional Perfusion, or NRP.
Right. NRP is performed in situ, meaning right there in the donor's body, just moments after circulatory death is declared.
Okay, in the donor.
Think of it like an immediate targeted resuscitation for the organs. Using a technique similar to ECMO, it restores oxygenated blood flow right to the abdominal organs, so the liver, kidneys, pancreas, for maybe 30 minutes up to 2 hours.
Wow.
And this immediate reperfusion, it flushes out harmful metabolites, it reestablishes normal cellular metabolism, and it essentially resuscitates these organs before they're even retrieved.
And you mentioned it benefits multiple organs.
That's a crucial benefit, yes. NRP is a multi-organ approach. It treats all those abdominal organs in the same procedure.
Okay, and then there's the other one, Normothermic Machine Perfusion, or NMP.
NMP takes a different path. It's performed ex-situ, so outside the body on the explanted liver itself.
After it's removed.
After it's removed, exactly. The liver is connected to a specialized machine that continuously pumps an oxygenated, usually blood-based solution through it at body temperature. This typically goes for 4 to 24 hours.
Now, this can happen during transport.
It can, yes, while the organ is transported or once it arrives at the transplant center. And NMP allows for a real-time assessment of the liver's viability. Is it clearing lactate, that marker of cellular stress? Is it producing bile?
Like a checkup for the liver?
It essentially puts the liver in an external intensive care unit, yeah.
And it extends its preservation window significantly. But unlike NRP, NMP is organ-specific just for the liver in this case.
Okay, so for this deep dive then, our mission is to unpack this fascinating comparison. What happens when we use both NRP and NMP sequentially, in combination, versus using NMP alone for these DCD liver transplants?
A really important question.
What does this mean for patient outcomes, for the quality of the organ itself, and ultimately, for the future of transplantation? We're going to try and extract the most important insights, give you a shortcut to really understand this cutting-edge medical advancement.
Sounds good. Let's start with the big picture then. Patient and graft survival and how well the liver functions right after transplant. And it's truly remarkable how far we've come.
Both approaches, NRP and NMP, have propelled DCD liver transplant outcomes to nearly match those seen with organs from brain death donors or DBD donors.
Wow, nearly matching DBD. That's huge. That's a massive leap forward. How do the numbers actually stack up?
Well, consider this. An international study looking at outcomes from 2015 to 2019 found that 2-year graft survival was around 92% for NRP-treated livers, compared to about 88% for NMP-only livers. Now, while that specific difference wasn't statistically significant in that particular study, it still paints a picture of really excellent outcomes for both methods.
Still very high numbers.
Very high. And perhaps even more compelling, single-center data from the UK reported a 3-year graft survival of 90% for NRP DCD livers versus 76% with NMP alone.
That's quite a difference there.
It is, though single-center data always needs context. But the key takeaway for you, the listener, is that in modern practice, both techniques consistently deliver graft survivals in the 85–90% plus range at 1 year.
Okay.
Which is just a dramatic improvement over historical DCD outcomes, which, were often much lower.
Right, right. What about those really scary scenarios like primary non-function, PNF, where the transplanted organ just doesn't work at all?
Yeah, thankfully PNF is exceptionally rare with either approach. It's really quite amazing. In fact, a U.S. multi-center series reported 0% PNF in NRP cases.
0%.
Zero. NMP also boasts very low rates, partly because the machine perfusion itself allows surgeons to identify and, if necessary, discard grafts with poor viability before they're even transplanted.
Ah, so it's a pre-transplant check.
It adds a crucial layer of safety, yes. And when NRP and NMP are used in sequence together, it appears to provide an even greater safety net. One report on 83 DCD liver transplants using NRP, and 21 of those also had NMP added observed absolutely zero PNF.
Incredible.
It's an incredible testament to how effective these methods are.
That is incredibly reassuring. And what about early allograft dysfunction, or EAD? That's when the liver functions, but maybe not quite optimally right after transplant.
That's another area where we see significant improvement. Both methods substantially reduce EAD compared to the old way, traditional static cold storage.
Okay.
A UK study, for instance, showed EAD in about 20.6% of NRP recipients versus maybe 8.8% for NMP, though again, that difference wasn't statistically significant after they matched the patients carefully.
Right.
But other analyses have even suggested that NRP can potentially have the EAD rate, maybe from 56% down to 36%. The bottom line is, both NRP and NMP dramatically improve that immediate liver function right after transplant.
So what's the practical implication here for you, the listener? It sounds like both NRP and NMP represent these tremendous leaps forward in DCD liver transplantation.
Absolutely.
They deliver dramatically better early outcomes compared to the traditional methods with high and quite comparable 1-year graft survival rates.
Yep.
It appears NRP, whether used on its own or maybe followed by NMP, might offer a slight edge in reducing that initial dysfunction, but it's certainly not inferior to NMP alone in terms of overall survival.
That seems fair to say.
This isn't just like an incremental step. It's really a story of marked improvement, bringing those DCD outcomes remarkably close to the gold standard, the DBD donors.
It really is a paradigm shift. Now, here's where it gets really fascinating, and it's a bit of a game changer. Let's talk about biliary complications.
The bile ducts.
Specifically, ischemic cholangiopathy, or IC. This has historically been a major Achilles heel in DCD liver transplants.
Right.
It often leads to severe non-anastomotic strictures that's narrowing in the bile ducts months or even years after transplant. And sometimes it's so bad it requires retransplantation.
A really serious complication. And NRP seems to have a truly monumental impact on this particular problem. Is that right?
Monumental is the right word, absolutely. NRP, almost unbelievably, virtually eliminates IC.
Eliminates it?
Virtually eliminates it. Multiple studies consistently report 0% incidence of IC with DCD livers that underwent NRP, and that's regardless of whether NMP was also used later or not.
Wow. Give us some context, some numbers.
Okay, so a Mayo Clinic series looked at 83 DCD liver transplants. They found no ischemic cholangiopathy in the NRP groups, 0, whereas those preserved with the old static cold storage method had a 16.8% rate.
Huge difference.
Massive. And a UK study reported 0 non-anastomotic strictures with NRP, contrasting sharply with 14% for static cold storage and, interestingly, 11% even with NMP alone.
Okay, so NMP alone helps, it's better than cold storage, but it doesn't completely solve the biliary problem.
Precisely. NMP alone definitely reduces IC compared to conventional preservation, which is a huge win in itself, don't get me wrong.
Sure.
However, it doesn't completely eliminate it. Early NMP trials, especially when they were using higher-risk grafts, still saw IC rates around 30%.
Oh, wow.
Now, more recent practices brought that down significantly, maybe to about 11%, particularly if NMP is started very quickly. But studies still show a residual incidence, maybe 5–15% of these strictures for NMP-lone grafts.
Compared to NRP.
Compared to NRP series, which consistently report rates in the 0–2% range. The difference is stark. It's really quite compelling.
So let's unpack the why. Why does NRP achieve this almost perfect protection for the bile ducts? What's the mechanism?
It really comes down to the timing and the nature of NRP's intervention. Remember, NRP restores oxygenated blood flow within minutes of circulatory death.
Right, that immediate resuscitation.
Exactly. During that initial period of warm ischemia, tiny blood clots, microthrombi, and fibrin deposits can form in the parabiliary plexus.
The what now?
The parabiliary plexus. It's this critical, intricate network of tiny blood vessels that supply the bile ducts themselves. Very delicate.
Got it.
If these microclots aren't cleared immediately, they just sit there and cause ongoing damage to the bile duct cells, leading eventually to ischemic cholangiopathy.
So NRP clears them out?
NRP acts like an immediate, powerful flush. It clears those blockages almost instantly because the blood flow is restored so quickly in situ. Essentially, by restoring perfusion so rapidly and effectively, NRP kind of turns a DCD organ into a state that more closely resembles a DBD organ at the time it's cooled.
Fascinating.
And this drastically reduces the downstream necrosis and injury to those bile ducts.
Okay, so for you listening, what's the core takeaway here? If the primary clinical goal is really to minimize ischemic cholangiopathy, which, let's remember, is a huge cause of graft loss and long-term problems in DCD liver transplants, then NRP offers a clear, almost unmatched advantage in preventing it.
Unmatched is fair, yeah.
It's like getting ahead of the problem before it can truly take root. It's preventative.
Exactly. It addresses the root cause of that specific injury pathway. All right, let's peel back another layer now and look at the liver's inner workings, its biochemical and metabolic outcomes.
Okay.
One of the great advantages of normothermic perfusion, both types actually, is that it allows us to monitor the liver's metabolism in real time.
And I remember reading something kind of counterintuitive about liver enzymes like AST and ALT with NRP. Right?
That's a great point, yeah. You'd normally expect lower enzyme levels to indicate less injury, wouldn't you? However, studies have shown NRP-recovered livers can sometimes display higher peak post-transplant AST levels. For instance, one international study found the median peak AST was around 872 UL for NRP versus maybe 344 UL for NMP.
So higher is?
Higher is okay in this context. Here's the kicker. This higher initial spike does not translate to worse clinical outcomes for NRP-treated livers. The graft function remains excellent.
So what does it mean then?
It likely reflects the intense immediate reconditioning and the flushing out of cellular debris that NRP achieves right at the start, rather than indicating ongoing damage. It's a sign of active repair and clearance.
Okay, that makes sense. What about lactate clearance? That's a really crucial viability criterion, right? Shows the liver is switching back to aerobic metabolism.
It absolutely is, and it's a cornerstone of assessment during NMP. A DCD liver on NMP, you expect it to clear lactate down to below maybe 2 or 3 millimole.
Right.
Now, what's compelling about combining NRP with NMP is that it offers this kind of double opportunity for lactate clearance. Well, livers that still had somewhat elevated lactate, say around 8.2 millimole after the initial in-situ NRP phase, were observed to fully normalize their lactate down to just 0.9 millimole by the end of the subsequent ex-situ NMP phase.
So NMP finishes the job.
Exactly. It means any metabolic deficits that weren't quite corrected during NRP can be fully tuned up during the NRP phase. It ensures a really complete metabolic recovery and provides an added layer of confidence, especially for those more marginal grafts.
Right, the ones you might be a bit worried about.
Precisely.
And bile production and its chemistry. I'd imagine that's a pretty direct indicator of how those bile ducts are doing.
Very direct. During NMP, we rigorously assess the bile production rate and its composition. We look at things like pH, bicarbonate levels, glucose concentration, to predict how well the bile ducts are functioning and likely to function long term.
And with the combined approach,
with the NRP+NMP sequence, surgeons often observe early bile output even during the NRP phase in the donor, which is always an encouraging sign. Then they can confirm robust bile flow and optimal chemistry during the NMP phase. And because NRP provides such proactive protection to the bile ducts, as we discussed, the bile quality is often excellent right from the very start.
So looking at the bigger picture here metabolically, the combination of NRP and NMP seems to ensure a far more complete metabolic recovery before the liver even goes into the recipient compared to NMP alone.
That's a fair assessment. It's like a two-stage purification and reconditioning process, offering an added margin of safety, particularly for livers that might otherwise be considered borderline or high risk.
Got it. What's truly fascinating here, too, is how microscopic analysis, looking right inside the liver tissue, reveals the profound benefits of these techniques.
Yeah, histology tells a great story. It lets us literally peek inside and see how they influence ischemic injury, cell death, even down to the level of mitochondria.
We mentioned earlier that warm ischemia primarily damages the cholangiocytes, those bile duct cells, and the sinusoidal endothelium, the lining of the tiny blood vessels inside the liver. How do NRP and NMP help with that?
So NRP, because it's performed so early, it restores the function of that sinusoidal endothelium and the perfusion of the bile ducts before the organ even hits cold storage.
Okay.
This significantly limits the initial warm ischemic damage. Animal models have clearly shown that livers receiving NRP have far less hepatocyte necrosis, that's liver cell death, and fewer apoptotic cells, those cells undergoing programmed death.
And crucially for the bile ducts.
Crucially, the parabiliary plexus, that vital network of tiny blood vessels supplying the bile ducts, remains open and clear with NRP.
Because it flushed out those microclots.
Exactly. NRP effectively flushes out the microthrombi and fibrin deposits that would otherwise clog these vessels. NMP alone, especially if it's started after a significant warm ischemic period, simply can't undo that initial thrombotic damage that's already occurred.
Right, the damage is done.
The initial damage is done. NMP can help maintain things, but NRP prevents it.
And on the energy front, mitochondria and inflammation.
Yeah, both NRP and NMP are critical for maintaining the liver's energy factories, the mitochondria, and supporting oxidative phosphorylation. That's the process that creates ATP, the cell's energy currency.
Okay.
NRP regenerates ATP in situ, restoring the liver's energy stores right away. NMP then helps maintain those stores ex situ. And the sequential NRP plus NMP approach consistently shows minimal signs of that reperfusion injury we talked about. For instance, much lower neutrophil infiltration, which is a marker of inflammation.
So less inflammation overall.
Less inflammation. Both methods also efficiently flush out inflammatory cytokines and those damage-associated molecular patterns, or DAMPs, the distress signals released by injured cells. This likely results in significantly less post-transplant inflammation for the recipient.
So the unmatched advantage, if we boil it down histologically, is really this. The sequential use of NRP and NMP yields a graft that, both microscopically and molecularly, looks remarkably like a non-DCD liver, maybe even a standard DBD liver.
It's getting remarkably close, yes.
And this is evidenced by very low levels of biliary fibrosis in histology that's comparable to DBD grafts. So while NMP alone certainly improves graft quality over cold storage,
Absolutely, it does.
the combination truly maximizes the preservation of the liver's normal architecture, giving the recipient the best possible starting point.
The best possible graft, exactly.
It all sounds incredible, technically and medically, but it raises that important practical question. Do these advanced techniques actually justify the cost? Transplant procedures are already incredibly complex and expensive.
It's a completely fair and critical point. Let's look at the direct costs first. NMP, the machine perfusion of a single liver, can range anywhere from, say, 4,000 pounds to maybe 20,000 pounds per case, depending on the system and duration.
Okay, quite a range.
NRP, on the other hand, costs approximately 4,500 pounds per procedure. But here's the critical difference. That cost covers all the abdominal organs retrieved from that donor.
Ah, so they also get kidneys.
Exactly. If kidneys or a pancreas are also recovered and transplanted, NRP becomes very cost-effective on a per-donor basis. Combining NRP plus NMP, of course, means you incur both sets of costs.
Right.
So it's typically reserved for those situations where the benefits are clearly justified, like for very marginal livers that might otherwise just be discarded.
However, the cost discussion, it extends far beyond just those direct expenses, doesn't it?
Oh, absolutely. Both techniques dramatically increase DCD organ utilization. That means more organs are successfully transplanted from the same number of donors, which has broad economic and, frankly, societal benefits.
More lives saved.
More lives saved, less time on waiting lists. And NRP, in particular, has been shown to significantly reduce the non-use, the discard rate of DCD livers.
And what about that IC connection?
Right. Studies project that if NRP lowers the incidence of ischemic cholangiopathy, our old friend IC, below a certain threshold, which is around 14% compared to standard recovery, it becomes highly cost-effective.
Why?
Because it avoids those incredibly costly retransplants and the complex long-term management that IC complications require. And since NRP routinely achieves IC rates near 0%,
It easily meets that threshold.
it easily meets and surpasses that threshold, making it very cost-effective from that perspective alone.
And what about the less obvious costs and savings? Like NRP takes extra time in the donor OR,
Yeah.
right? But does that balance out with maybe shorter hospital stays for the recipient?
Exactly. That's the trade-off. NRP does require keeping the donor in the operating room for an additional 1 to 2 hours, which incurs staff and OR time costs, no question.
Okay.
However, these costs are often more than offset by significant savings down the line from shorter recipient ICU stays and shorter overall hospital stays. For example, NRP has been associated with a median reduction in hospital stay from 10 days down to just 7 days.
That's significant savings.
That can save many thousands of pounds or dollars right there. Plus, preventing IC and the need for expensive invasive interventions like multiple ERCPs or even complex biliary reconstruction surgeries. That further contributes to long-term savings and, just as importantly, a dramatically improved quality of life for the patient.
So while NRP plus NMP might have the highest upfront cost on paper,
It does.
it undeniably provides the best outcomes in many cases.
Yeah.
And it seems truly justified for those challenging situations, the marginal livers, the long-distance procurements, where the cost of graft failure or a retransplant would be exponentially higher.
Absolutely. It's a compelling example of how investing upfront in prevention, in this case preventing graft failure and major complications, can easily pay for many perfusion runs down the road.
If we connect all these pieces now to the bigger picture, it's really about how these methods actually play out in real-world practice. There are significant logistical and technical considerations for both NRP and NMP, and especially when you combine them.
There are, yeah. Logistics are key in transplantation.
So let's talk about geography and transport first. How do those influence the choice of strategy? Does distance matter?
Distance matters a lot. NRP, remember, is performed at the donor site, usually in the donor hospital's OR, and then it's typically followed by standard cold transport of the organ.
Okay.
NMP, however, offers more flexibility. It can be initiated either at the donor hospital, requiring transporting the machine and team there, or it can be started once the organ reaches the recipient center. That's often called back-to-base NMP.
Right.
Now, for incredibly long distances, or when transport is complex or delayed, NRP plus NMP becomes particularly beneficial
Why is that?
because it allows for continuous warm perfusion during that prolonged travel time, minimizing the total cold ischemia time. This sequential approach can effectively create an almost ischemia-free transplantation scenario, which is revolutionary.
Wow.
While NMT alone can also handle long distances, using NRP first means the organ is already resuscitated before that long NMP journey even begins.
Okay. And timing and scheduling, especially thinking about the recipient surgery, that must be a huge factor for the teams.
Oh, absolutely huge. One of NMP's great strengths is its ability to extend organ preservation, sometimes for 12 hours or even longer.
Right. Keeps the clock from ticking so fast.
Exactly. And this is a massive logistical advantage for transplant teams because it allows for scheduled daytime transplantation rather than those urgent, middle-of-the-night emergency procedures. Much safer, much better for everyone.
Sure.
NRP alone doesn't offer this extended preservation window. After NRP, the organ is still typically cooled and needs to be transplanted within a relatively standard time frame.
About the combo.
But by adding NMP after NRP, you truly get the best of both worlds. The organ is optimally reconditioned by NRP first, reducing that IC risk, and then it can be kept stable on the NMP pump until the recipient and the entire surgical team are perfectly ready.
That seems invaluable.
It's invaluable, especially for complex recipients who might need more preparation time before their surgery.
It sounds like there's quite a bit of technical complexity involved for both methods, and maybe even more when you combine them.
You're absolutely right. NRP requires a highly experienced retrieval team and an ECMO setup readily available in the donor OR, which, as we said, adds about 1 to 2 hours to the donor operation. It's a specialized skill set.
Okay.
NMP, on the other hand, is typically managed at the recipient transplant center by trained perfusion specialists and the surgical team there. Combining them means you need both specialized skill sets available and, crucially, a meticulously coordinated handoff between the two phases.
So communication is key.
Communication and timing are critical. Any significant delays during that transition from NRP to NMP could potentially reintroduce a small period of warm ischemia, which you really want to avoid.
Right. What about their applicability? Is NRP only for DCD, and are there multi-organ benefits?
Good questions. NRP is specifically designed for DCD donors to counteract that initial warm ischemia. NMP, however, is more broadly applicable. It can be used for DBD livers, DCD livers, and even living donor grafts sometimes. The NRP plus NMP combination is typically reserved for the most marginal DCD cases, think organs, from very elderly donors, for example. One study showed a remarkable 100% 8-month survival using the sequential approach in DCD donors who are over 80 years old.
Incredible.
Truly, and crucially, remember that multi-organ point. NRP benefits other abdominal organs recovered from the same donor, like the kidneys and pancreas. This leads to superior function and lower rates of delayed graft function for those organs, too.
Ah, so NMP doesn't help the kidneys.
NMP is organ-specific, so that's a significant multi-organ advantage that NRP provides over NMP alone.
So really, it seems these are less competitors and more complementary technologies, each solving different pieces of the DCD puzzle.
That's exactly the right way to think about it. NRP tackles the devastating impact of warm ischemia head-on, especially the risk of ischemic cholangiopathy. NMP overcomes logistical hurdles by extending preservation time and allowing for detailed viability assessment.
Different jobs, same goal.
They address different yet equally critical aspects of organ preservation for DCD donors. Finding the right balance, deciding when to use NRP alone, NMP alone, or the combination, is really the evolving art and science in liver transplantation today, constantly pushing the boundaries of what's possible.
So just to recap then, combining normothermic regional perfusion with normothermic machine perfusion, NRP plus NMP, truly represents an advanced strategy. It seems to unlock the full potential of these DCD liver grafts.
It really does.
The clinical evidence strongly suggests that using NRP and NMP together yields excellent graft survival, remarkably low rates of that early dysfunction, EAD, and crucially, virtually zero ischemic cholangiopathy.
Zero, I see, yeah.
Even in the most challenging scenarios like long-distance retrievals or organs from very old donors.
That's spot on. Compared to using NMP by itself, the addition of NRP upfront offers that unparalleled biliary protection and an immediate, robust initial resuscitation of the organ. NMP then comes in to add extended support, allows for that detailed assessment, and lets the team fine-tune things metabolically. Together, they ensure safer organs and much smoother logistics.
Which translates directly to significantly better outcomes for patients waiting for that second chance.
Absolutely. Better outcomes, safer transplants.
We've definitely explored the higher upfront cost and the added complexity of doing the NRP plus NMP sequence. But it seems pretty clear the investment is profoundly justified by preventing those catastrophic graft failures and dramatically expanding the use of DCD organs.
Yeah, it really changes the equation.
This isn't just a medical advance, it feels like an economic and a societal one too.
I agree. Preventing even a single graft loss or a retransplant, with all the cost and patient suffering that involves, can easily offset the cost of many, many perfusion runs.
Yeah.
And the exciting thing is, as you said, the field is moving beyond viewing NRP and NMP as strictly either competitors.
Right.
Instead, the focus is increasingly on embracing both as needed, tailoring the preservation approach to ensure each DCD liver recipient gets the absolute best possible graft for their specific circumstances. It's becoming more personalized.
And that really leads to a truly provocative thought for you, the listener, to take away. How might this personalized multimodal approach to organ preservation redefine what's possible in transplantation? Not just for livers, but potentially for other organs like kidneys or the pancreas too.
Yeah, the potential is huge.
What could the long-term societal impact be of safely expanding the donor pool to this degree, making these life-saving transplants available to so many more people who are desperately waiting? It's a future that, thanks to innovations like NRP and NMP, is rapidly becoming today's reality.